Thank you. At the outset, I'd like to thank Dr. Siddharth and the Chairman AIOC Scientific Committee for providing me this opportunity to speak to you on GATT, patient selection, and my experience. So, as Dr. Mahesh has mentioned, there are numerous ways where you could practice intraoperative gonioscopy. Of course, you have to do gonioscopy in the outpatient department, that's a given, but in the operating room, you should practice intraoperative. There are a lot of opportunities to us, especially when you remove angle foreign body, when you want to assess scleral wound. For example, the image in the lower portion, you have a fish mouthing of the SICS section. So you want to see what is happening inside. You do that in the operating room also, as well as in the OPD. When you want to repair a cyclodialysis cleft, when you implant a glaucoma drainage device in the sulcus, you can see where it is being fit correctly. It's too far extended or before, you could use intraoperative gonioscopy. Goniocycling, like you can even use a Sussman lens in the OR. If you have ETA'd it and you're prepared for it, you can use the Sussman lens to look at all the angles. And patient positioning already been done. I think Dr. Swati may also mention it's important that we consider the reverse Trendelenburg position to reduce the reflux of heme into the eye. And now we have all the equipment. We don't have any shortage of equipment. That's why we are able to do much better now. We have good quality forceps. So micro forceps are very important. You could also use the micro rhexis forceps. I'm going to show you a video where we use a micro rhexis forceps to push the suture into the so you don't have to run to the retina department, borrow the micro forceps and start doing the procedure. Or if you have one only with you and it's been used, you can use your micro rhexis forceps to do the, make sure the tips oppose very well. If the tips don't oppose and there's a gap, for example, I'm struggling to catch hold of the suture, and when I take out the forceps outside, when I clip this, the tips are not opposing. Can you see that? So that's a defect. So you introduce it into the eye, then you realize the tips are not opposing. So make sure the equipment is good. And the gonio lens, as we already mentioned, these are the all n number of gonio lenses which are we have now. The Vogue original one was ergonomically quite unsatisfactory, but it still does the job. The original Vogue, the one before the TVG. And Prism S, Prism S is the one from Glaucos. It gives a very nice view. This is how it looks. And this is the Ocular Hill gonio lens. Swan Jacob does the work very well. Main advantage of Swan Jacob is you can post multiple patients because it's autoclavable. These are not autoclavable. Swan Jacob you can autoclave and use for multiple surgeries. And sutures, we use the 5060 poly. We get it from Oral Lab, and Dr. Swati and Dr. Siddharth, they prepare it in the OR, so that's a big advantage. And viscoelastic sodium hyaluronate is very important. I always leave sodium hyaluronate in the eye, almost 30, 40, 50% fill as much as possible. And table height, positioning, and surgery time is always dicey. Sometimes it takes 5 minutes, sometimes it takes 1 hour. So at the beginning, be prepared to have a lot of perseverance. And then as you get by, you can do it a little faster. And this is a nice article from Dr. Vinay Gupta's group. He had a, I think, free paper competition with Dr. Siddharth, where he showed the types of angles, Jonal angles, in the free paper section. So normal appearing angle is the best angle to operate in. So that's the one to go to. Avoid featureless angles. If you see a featureless angle, those don't do so well. There are actually some sort of dysgenesis is there. High iris insertion and prominent iris process also do pretty well. So that's something which I teach my fellows there. And we always try to pick up patients who have only this type of normal angle anatomy. Avoid featureless angles. There's a tissue is totally abnormal. You may never get into the Schramm's canal. You may pass the suture, it may come out anywhere. So it's very, very tricky. And this is an example of a featureless angle. You don't see any demarcation except the ciliary body band slightly, but otherwise it looks non-pigmented, slightly pale. And this is an angle with slightly high iris insertion. So you could see that it's slightly high iris insertion, but it still will tear the trabeculum meshwork, and you can perform a very good procedure. This is again a high iris insertion. Iris processes are extensive, and this is somewhere you don't see the exact features very clearly. So be very careful with such angles. The ideal patient would be a POAG patient with cataract. So you could do the cataract first or do the cataract later. Normal tension glaucoma with cataract also is okay. Even patients with glaucomatous optic atrophy, near total glaucomatous optic atrophy, the idea is that you can reduce the intraocular pressure transiently, and then you can plan for your subsequent surgery later. So the prognosis is really very poor, and because of that, because it's a closed globe procedure, there's not any prolonged hypotony. These eyes do pretty well compared to a trab done in these eyes. Patients on minimal duration of medication. So recently diagnosed patients on many medications. There are other the most gratifying patients are patients who have got trab in the other eye. So if you do a GATT in this eye, it works like magic, and they are the most gratifying patients. Avoid patients with high expectations. So never tout it as something like a sutureless surgery. We never tell them that it's going to be we never use the word sutureless. So we always say it's going to be a pressure reducing surgery. So in case you have to convert to a trabeculotomy, which is again the same thing, you could just convert with a trabeculotomy. Patients with abnormal angle, hamartomas, for example, Sturge-Weber syndrome, avoid such patients. They are not ideal candidates for this procedure. Nevus of aorta is another one condition. So this is just to show you a video how you struggle during the procedure. So the suture's gone in, and make sure that once the suture has been placed inside, then I give the nick. So there are three places where you can cut the trabecular meshwork. You can cut it on the higher level, the mid level of the trabecular meshwork, or the lower level of the trabecular meshwork. If you cut the lower level, very easily the suture can go. So this is the bubble trouble. So once you inject the viscoelastic, make sure you inject viscoelastic outside and then go inside and inject viscoelastic. So avoid that. And then you catch hold of forceps and introduce into the trabecular meshwork. This should be a little easy, but there will be a little bit of struggle. As Dr. Mahesh has mentioned, your arms are extended, so you have to reach out and do the procedure. So it's technically a little difficult. You have to get the hang of it. And once you have introduced the suture, you should have some resistance to movement. If you don't have the resistance to movement, so I'm introducing it, it's going, and I've introduced a significant proportion of it. But as I'm introducing, the suture has actually has cut the trabecular meshwork, and in the right side, on the corner, if you see, the suture will be visible in the gonio lens. So it's actually has cut and come inside. So these are the early learning problems which you will have. It depends. Sometimes I feel that it's mainly because of the umbrella tip. You can see the suture there, just past. So it's mainly because the umbrella. If the umbrella is kinked at an angle, then it can tear inside. So make sure the umbrella is correctly perpendicular to the suture stem. Then after this, I'm going in the reverse direction in the same patient. And I find that it's gone into the sulcus. It's going in very smoothly. It's made a passage and it's gone into the sulcus. It's not in the anterior chamber, so it's been, and the pushing, I don't feel any resistance. So because of that, I come out again. I clean the eye, wash the eye, and then I do it anti-clockwise again. So you see the trick here is it's entering into the angle straight. It's not following the curve of the globe. So the important thing is it should follow the curve of the globe. If it's not following curve of the globe and it's tangential, that means it's in the false passage. The same patient again, we bring it out and then introduce it slightly higher up in the cut edge of the angle, trabecular meshwork. It pops out, then I go a little bit behind, further behind, and follow the curve of the globe and then introduce it. And once you push it, you need about 19 to 24 pushes. So that's people recommend not to use the stroke, but rather than to maybe make it a kink. But sometimes the kink we are not able to see or visualize. So I rather prefer to use the number of strokes. About 19 to 23, 24 strokes are required. So the same patient, we went in anti-clockwise, wasn't happening. We went in clockwise, that wasn't happening. Then we came back and again went anti-clockwise, that worked. So the important thing is that's why it takes 50 minutes. So you should not lose perseverance when you do the procedure. So this is another patient who came to us about after 1 year of the other eye. So this is how you initiate the surgery. Sorry, just a second. How you initiate the surgery is, so the patients I'm showing you are phakic eyes. Most of them are juvenile glaucomas or early POAGs. Once you introduce the suture through the side port, I always try to place the side port supranasally or infranasally. And these gonius lenses required some sort of coupling device. So you use the OVD, and then when you tilt, use the focus and fine focus to visualize the angle. So you should have an unfast view. So the trabeculum meshwork should hit your eye directly. So it's like looking at a mirror right in front of you. It should have a good view, and give a nick. And because of you could see the chemosis, the subtenance block was so heavy, so you have and the suture just come out. So I have to introduce the suture again. When you lifted the lens, the suture came out. So be very careful, and then again remember the bubble trouble that always causes a problem. And once you have identified, blood is actually good, mainly because it helps you to identify where the incision has to be placed, blood in the Schramm's canal. Sorry. Oops, I think the view isn't very good. So this, because of the peribulbar block, the subtenance block, the chemosis was so severe that the patient had a severe regurgitation of blood from the Schramm's canal. That's better. Okay. And you will have to apply, come out, put viscoelastic, go back in, do the procedure, come out again, put viscoelastic. That has to happen constantly. Sometimes the bleeding is so much it covers the interface between the lens and the cornea. So that also we have to keep cleaning the lens at the bottom. And then once you are through, you pull the suture and do the trabeculotomy. And once that is done, it's important to wash, and I'll show you. Then come back to the original position, wash with the IA or Simcoe, whatever you're familiar with. And finally, I always use almost 30–40% fill of viscoelastic in the eye. Sometimes even up to 60% I would like to leave viscoelastic. When you are taking out the suture, make sure that it's done very slowly and you don't nick the anterior capsule. That's another thing which you have to remember when you do the. So this is how you fill the chamber. So we use sodium hyaluronate only, the normal one 1.4%, and leave almost 60% fill into the anterior chamber. And this is the same patient post-op day 1. You could see there is bleeding in the eye, blood clots, and you can see the vision is 6.6. The intraocular pressure is 10 millimeters of mercury, and chamber is filled with viscera. You can see the reacting pupil very nicely. So patients do very well. They don't have any sutures. They feel very gratifying. This lady actually came to us after getting the other eye done for 1 year after that. So she wanted to see, she has a medical background, not medical but science background. She wanted to see the response of the procedure after 1 year. So that's on the left side is the right eye which we had done 1 year back, and this is the freshly recently operated eye. So she wanted to see what is the result, and then she wanted to undergo the other. So both the eyes are now off medication. So you could also, this is another patient whom we had operated. She is high myope, minus 12 D sphere, and she had a high FEMA on the first day, but she was reading well. We tapered the steroids, and pilocarpine we used for 2% just for because the intraocular pressure was hovering around 17 to 20 millimeters of mercury. So this is the results of our brief publication, which we had short publication. We had juvenile glaucomas, uh, secondary open angle, pigment dispersion. So we operated baseline IOPs was quite high, 40, 25, 44, 24, 34. They all multiple medications. At the end of the only 2 patients did not do well. That's a nevus of and viral keratitis patient with secondary glaucomas. But other patients we were able to bring down to good low intraocular pressure levels at 1 year follow-up. So intraoperative complications, poor view of the angle structures mainly because of positioning. So not accessing the Schlemm's canals because the gonioscopy is actually, maybe that's not the correct patient we are trying to do the procedure in. Bleeding will come, how we can control the bleeding. Iris prolapse can occur, especially if you use a 2.8 millimeter incision instead of a 2.2. So be very careful. Some people try to do through a side port. That's even a better idea. Lens touch, especially when you're manipulating the suture or introducing the instrument into the eye. Cyclodialysis can be caused, and iridodialysis can also be caused. Some literature is there in which you can even cause a Descemet's membrane detachment. So positioning of the patient is very important. So make sure that the positioning, sometimes after 10-15 surgery we become very lax. Okay, why 35 degrees of tilt? Why can't we do it in 20 degrees? Why to tilt so much? And also you start doing it like 30 degrees, 35 instead of 30, 35. Then you say, okay, even if 35 is okay, we can do it in 25 degrees. So that shouldn't be, it should be more. So if you've done the first cases, everything goes through very nicely and you're not getting the hang of it next time, that means something's wrong somewhere. So the laxity shouldn't come. It should be always more, but not less. So tilt of the microscope and tilt of the head should be more than 35. So whenever you have a problem, move the patient's head more away from you. And this is what you have to continuously teach your junior colleagues also. If they don't tilt their head sufficiently, they will not be able to see anything. And if you're not able to do it, reconsider diagnosis there itself. Don't think that you could push the suture anywhere. Reconsider and be very careful of featureless angle. Not cannulating, I showed you, it wasn't in the same video. You are not inserting it into the Schlemm's canal properly. Always have a plan B. So the plan B for us is always an external trabeculotomy. So we always have an external trabeculotomy which we prefer to do. Angle anatomy, I would like to re-emphasize this because I find this the most crucial aspect. So in the OPD, gonioscopy has to be done very, very well. So before buying your surgical gonio lens, if you don't have a gonioscope in the OPD, please buy that first. So bleeding is important. You can have excessive bleeding. So keep the eye pressurized always. So always keep the eyes pressurized. Because of this, you can even operate advanced glaucomas, in which if you do a trap, the vision will drop to 5/60, 3/60. But if you do this, the vision remains better than 6/12. And when you keep the eyes pressurized, it helps to open up the Schlemm's canal. Schlemm's canal is like a rubber tube in the tire which has got punctured. So it just collapses. You introduce something into that, it will go and kink somewhere. So Schlemm's canal, if it has to be cannulated, my afternoon talk is on canaloplasty. I do the same procedure externally. So if the suture doesn't go, that means there's somewhere the Schlemm's canal has kinked. So inflate the eye properly. The Schlemm's canal, the inner wall and the outer wall have a tendency to collapse and stick to each other. So if the outer wall is collapsed, soft, the eyeball is soft, the outer wall and inner wall touch each other. Inner wall is more flexible, outer wall is stiff, but still the inner wall will touch the outer wall will touch the inner wall, and you cannot pass the suture. It can kink through and cheese wire. So if your suture is in antechamber, you have been doing the procedure in an eye which is very soft. Smaller incision, I already mentioned. Iris prolapse, to avoid that, use a 2.2 incision or even smaller. Move towards the nasal angle so that the introduction of the suture into the trabeculum Schlemm's canal is easy, and avoid large volume block. Lens touch hasn't happened to me so far, thankfully, touch wood. It's a rare complication. You can have a peripheral touch. Careful when the suture is brought out of the section. So this sort of, sometimes you have a whip sort of an effect. When the suture comes out, it comes out in a whip fashion. So be very careful with that. So when you bring out the suture, be very careful, take it out. If you're operating a phakic eye, take it out around over the iris and around. Cyclodialysis, you can have profound hypotony. So if you do a good GATT, you'll have a IOP of between 10 and 14. But if you're getting anything less than 9, search for the cyclodialysis cleft. 8 and so I had a patient who had a very POAG but very high lens vault. So I didn't think of it at that time. So it retrospectively hit me when he came for the evaluation. Then I did a scan. I saw his lens thickness was almost 4.9. So I was operating on him as though I was operating on a POAG patient, and it didn't occur to me that a POAG patient will have a high lens vault. So I was going over the lens and operating, and I caused a cyclodialysis cleft. And because of that, he was having IOP of 6 and 5. Then I saw the cleft. Then I said, okay, he developed cataract, thankfully. So I did the cataract and the cyclodialysis cleft together, direct cyclopexy. So that's how, things happen. So assessing the anterior chamber, we are looking at equipment which can do assessment of the anterior chamber sections. Very nice. So we need the lens wall data, lens thickness data, even before practicing these procedures. Small iridectomy you can always leave, and that's the small size which have just like iridectomy. There's nothing more than that. You don't have to really go after them. You just manage conservatively. Post-operative complications, so far if the case selection is good, you don't have raised IOP. If the case selection is not so good, then you'll definitely have a raised IOP. Shallow chambers can occur, especially if you don't fill the eye with OVD. So what happens? You have removed the resistance to the trabecular meshwork. You are pumping the patient with anti-glaucoma medicine till day 1, even till, so the washout effect hasn't happened. Whatever has to be retained in the eye cannot be retained because you open the trab meshwork, so everything flows out. So what happens to the eye? What happens to the eye is the ciliary body cannot produce aqueous at the rate at which you expect it to. So everything moves forward, and there is a supraciliary effusion. Some people have reported that. So if you leave the eyeball soft without viscoelastic, you can have this. We had 2 patients have this, and then it became something. It will present something like an acute angle closure glaucoma. So you'll get into a misdiagnosis, whether do a PI, not do a PI, and all that. So it's very, very careful. You have to be careful. Look at the physiology of the eye and then take a decision. You are giving him 4 or 5 anti-glaucoma medicine till yesterday. You open the trabecular meshwork today, and aqueous is not getting produced. Aqueous is flowing out at rapid rate. And what happens to the chamber? So you have to think about it. High fever can occur, so make sure you avoid taking initial patients who are hypertensive, who are an so always measure the blood pressure, make sure that blood pressure is under control. And also post-operative PAS formation, you can have the patient, myope patient whom we had the other eye when we had extensive PAS formation. They present with raised IOP. So immediately go back in, remove the PAS, they start functioning very well. PAS is actually a good sign. So if you have PAS, it's a good sign that flow is good, number 1. The excessive flow is being arrested by PAS. If you have extensive PAS, that means the chamber has not been maintained well. So you have to go back and they will fail. So you have to go back and release those PAs. 1 or 2 areas of PAS is good. They don't extend, they don't go beyond that particular area. Late bleeding can occur, so be very careful when you are operating patients who are hypertensive, diabetic, and also very high chance of going in for a cardiac event. So if they are put on clopidogrel, they'll be in a soup. If you're driving and you have bleeding, you're going to crash somewhere. The patients are going to crash somewhere. And failed GATT, what are you going to do for failed GATT? The next option is always usually a trab, but be very careful when you do trab in failed GATT eyes, you can get profound hypotony. So don't use mitomycin C, apply tight sutures, release the sutures late, because GATT works. It's not that it's not working optimally. It's not working to the level which you expect it to work, but actually it was working because you remove the trabecular meshwork. So you can get a profound hypotony. So I'll stop here. Any other questions? I think after this session we can take. Thank you.